development of prostate cancer and how to diagnose prostate cancer, how to evaluate, and finally the management. The prostate cancer means the cancer that occurs in the prostate gland, which is located just beneath the bladder around the prostatic urethra. This is a gland which is connected to the bladder and the urethra, and the prostatic secretions are come out to the urethra. So, how the prostate cancer, what are all the risk factors for development of prostate cancer? Let us discuss about them first. Generally, this cancer occurs in elderly men, more than 50 years, and very unlikely to happen in men less than age of 40 years. So that itself is the risk factor. Sometimes chronic prostatic infections may lead to prostate cancer. Certain people have the family history. Certain genes are described. So certain people have the family history. So one is family history. The other one is chronic infections in the prostate gland. Certain other risk factors like smoking, patient being obese, diabetic, and certain patients who have the chronic enlarged prostate, which can be the fertile source of cancer developing in the prostate. So these are all the risk factors I just mentioned, like the family history, chronic infections, diabetes, smoking, obesity, and certain patients with chronic enlarged prostate, that is called benign prostatic hyperplasia, BPH. These are all the basic risk factors for prostate carcinoma, the cancer occurring in the prostate gland. So once the patient develops a swelling in the prostate gland, how he presents, what are all the symptoms with which the patient may present. These are very important, which leads us to evaluate the patient. Like increased frequency of maturation, having some incontinence, overflow or dribbling, increased frequency of maturation. Sometimes it may present with hematuria. Most of the times, these three symptoms will be there. Most of the times, increased frequency of maturation and overflow dribbling will be there. So the patient will have to get up more times in the sleeping time, and that could bring us the patient to the clinician. As soon as the clinician sees the patient, we generally write serum PSA. This is a blood investigation, serum prostate specific antigen, and we advise based on the PSA value. Suppose if the PSA value is raised and the patient will be examined before doing serum PSA by the clinician, we will be doing a rectal examination to assess the enlarged prostate. So based on his enlarged prostate, the clinician prescribes serum PSA. PSA value, if it is raised, generally a clinician will advise transrectal ultrasound guided biopsy. This transrectal ultrasound guided biopsy is going to yield us the diagnosis. Generally, this biopsy will be done either by the three specialty doctors, from the oncology, urology, and radiology. So after this biopsy yields us the diagnosis of prostate cancer, we generally read the report in the way of Gleason score. So Gleason score is very important. Suppose if it is more than 6, this becomes a high-grade prostate cancer. If it is less than 6, it becomes a low-grade prostate cancer. Based on that, we are going to describe the prognosis of the patient. So once this much evaluation done and diagnosis is there, a little bit risk stratification is also available, and everything is done. Now what is being left is whether we can operate on the patient or not. So for the staging purpose, generally we do a PSMA scan, PSMA PET scan, gallium PSMA PET scan. This PET scan shows the disease extent locally. Is it confined to one lobe, or it is involving both the lobes, or is it involving the median lobe, like that? And also any metastatic disease throughout the body. These two things can be evaluated. So PSMA is very vital in deciding the operability. Once we do the PSMA scan and the operability is assessed, we need to look at the age of the patient, how much severity the symptoms are, what is the life expectancy of the patient. What is the life expectancy of the patient? Suppose if the life expectancy is more than 10 years, this surgery is very ideal. Patient is elderly, more than the age of 70, having less life expectancy, less than 10 years. Surgery may not be that useful. Those patients can be monitored. Those patients will be kept on follow-up. So while surgery, so the patient is being decided to get operated and the surgical plan is decided. What surgery we are going to perform on a particular patient. This is going to describe the details of the surgery. The procedure we do is called radical prostatectomy. Generally, a nerve-sparing radical prostatectomy. There are three approaches that are being utilized by the concerned specialty people: open, laparoscopy, and robotics. Actually, the open procedure is very cumbersome. Radical prostatectomy, that suturing is very difficult in the pelvis depth. And laparoscopy also, laparoscopy can be done comfortably. The surgeon is very confident and is good at suturing in the pelvis, in the limited area. Laparoscopic radical prostatectomy can be done and it is being accepted worldwide. But the concept of robotics started with this radical prostatectomy. So robotic radical prostatectomy is a procedure that has been there, described and being done since almost 2 decades. Robotic concept has come for the radical prostatectomy, where later it got applied to all the other specialties also, like surgical oncology and gynecology. So basically, the robotic radical prostatectomy is a procedure where the anastomosis in the pelvis, once we remove the prostate gland, the suturing of the urethra to the bladder neck is much better with a robotic needle cutter. Here, the surgeons should be very meticulous in areas based on the stage, suppose if it is early stage or locally advanced stage. The surgical candidate will be the early stage prostate cancer. So the locally advanced stage prostate cancer people will generally go to radiation treatment. Early stage prostate cancer, the patient is planned surgery, that is robotic radical prostatectomy. During the procedure, what precautions we have to take? Initially, we mobilize the prostate gland in such a way that it is free from all its surrounding structures. From the rectum, anteriorly, everything mobilized. So 2 areas where we have to be very meticulous is, one is at the neurovascular bundle. The prostatic venous plexus along with the nerve fibers should be carried down to the patient's side. and as many nerves as possible should be preserved. And in the distal dissection, you should maintain that adequate length of the urethra. These two concepts are going to help in the patients to improve the continence of the patient. So this is the advantage with the robot. This is one concept. Second thing is the anastomosis of the urethra to the bladder neck without any structure. These two advantages of robotics has dramatically changed the role of robotics in the prostate cancer surgery. And this is the origin for robotics, and which got wider applications in multiple subjects, and it has got stupendous success in various areas. So the prostate cancer surgery is standard surgery. It's like mathematics. There were much variations. What a surgeon needs to understand is how you handle the neurovascular bundle and how you handle the urethra of the patient during the surgery. So once the surgery is done, patient most of the times, if suppose if it is early prostate cancer, most of the times the patient will not be needing any kind of adjuvant treatment. Suppose if it is a margin positive disease, then yes, patient may need some adjuvant radiation treatment, additional radiation treatment. Supposing if the disease is not operable, the disease is extending into the seminal other structures, then it becomes a locally advanced prostate cancer. Here, the role of surgery generally will track back. The patient will be given radiation treatment, and based on the response to the radiation, a future surgical plan may be decided. Suppose on the PSMA scan, if we found bone mets lesion, disease has gone to the bones, disease has gone to the lungs and liver. Suppose in this scenario, there is no chance of any surgery. The patient will be kept on chemotherapy. Most of the times, patient with bone mets will have a severe bony pain. And in this scenario, definitely there is the role of bilateral orchidectomy, that is testicular removal. In this, we do a subcapsular orchidectomy, and retain the capsule within the scrotal sac. This is going to give immediate dramatic relief, more than 50% reduction in the pain intensity. And this is going to be definitely help in the general improvement of general condition of patient. And some patients may have sometimes PSA becoming normal after bilateral orchidectomy also. Suppose if the patient doesn't respond to this bilateral orchidectomy, that prostate cancer is called castrate-resistant prostate cancer. This castrate-resistant prostate cancer patients will be given chemotherapy. This chemotherapy you have to take regularly, and the response to the chemotherapy in the case of castrate-resistant prostate cancer, results are not so good. So anywhere you go, whatever the treatment you describe, the best option for prostate cancer patient is in surgery. Suppose if it is early prostate cancer, robotic radical prostatectomy. If it is metastatic prostate cancer, again bilateral orchidectomy. The role of radiation comes when there is a locally advanced prostate cancer or post-surgery additional radiation. The chemotherapy is metastatic prostate cancer, the disease that has gone to other organs. So chemotherapy role is a little bit limited in case of prostate cancer. So these are, suppose if the patient's age is more than 70, a life expectancy is less than 10 years, then the role of surgery is excluded. The patient will be kept on surveillance. The patient will be asked to come for regular checkups. The clinician will do distal rectal examination, advise serum PSA. Based on these investigations, the patient will be kept on follow-up. So this is how prostate cancer is being treated with the three modalities of treatment, that is surgery, radiation, and chemotherapy. And various risk factors, how the prostate cancer patient presents, how the patient is evaluated, what is transrectal ultrasound guided biopsy, what is the biopsy report, what is the Gleason score. Based on that, the treatment decision is going to depend, and what is a PSMA scan, which is going to evaluate, like a PET scan, the disease elsewhere in the body. These different risk factors and symptoms being described. And is there any way to prevent prostate cancer? Most of the risk factors are irreversible risk factors. Certain risk factors like smoking, diabetes may be a reversible risk factor. Certain patients, if they undergo TURP for benign prostatic hyperplasia, it may be protective from prostate cancer in the future. These are small ways how a prostate cancer will be prevented. So most of the patients with the prostate cancer, they do well. Their prognosis will be better. If it is operated, it's well and good. Most of the patients will have a normal survival. Suppose if it is metastatic prostate cancer, patient underwent subcapsular bilateral orchiectomy. Certain patients are there, even metastatic prostate cancer, surviving well more than 5 to 6 years. So the patient with prostate cancer need not worry. This is not a dreadful cancer. Need of the hour is timely intervention, timely treatment, taking treatment, and different modalities of treatment already being described. And the role of robotics. Robotics, we can say it is the one of the pioneer procedure, robotic surgery, robotic radical prostatectomy is a pioneer procedure. The concept of robotics started with prostate cancer surgery. So definitely, it is not a dreadful cancer. It can be treated nicely. Patients will have reasonably very good survival. So there is no need of any panic. Thank you.